Shall we get going, Dana?
I'm ready when you are.
Okay.
All right, guys. Well, welcome to our first piece of the CAUTI CLABSI initiative that we're working on through the month of June. It's June 1st. I can't hardly believe it, but we are super excited to have Kathleen Bowman taking part in this. She has so much knowledge and is just really fun to listen to. So we're all very excited. So welcome. My name is Dana Steiner. I work with the Nebraska Hospital Association on the Age Quick Quality Grant. So we focus on decreasing harm within the hospital. And so CAUTI CLABSI, as we know, is an issue across the board and has even probably increased through COVID. So really excited to get kind of the new and upcoming best practices and discuss what we can do to better take care of our patients. Now, this morning session is focused mostly on providers' role. We do have a session starting at 11 Central Time that will focus more on the frontline staff. And then next week will be the CLABSI version, same deal. And then late in June, we have the 3 in-person educations that Kathleen will put on, more hands-on, more looking at products, those kind of things. So if you haven't got signed up for those and you're interested, holler at me or Amber, and we will get you on the list. If you are joining us just slightly late, please put your name and organization and your role into the chat, just so we better understand our audience. And I will quit talking and turn it over to Kathleen.
Thanks, Dana. And thanks, everybody, for carving the time. I know it's not easy. My name, as Dana said, is Kathleen Bowman. Background, 41 years as a critical care nurse, 10 directly at the bedside, 13 at the bedside as a clinical nurse specialist for the medical intensive care units at Henry Ford Hospital in Detroit, Michigan. And since 2003, I've had my own company called Advancing Nursing. And basically my role in this, I'm a subject matter expert for the American Hospital Association on CAUTI and CLABSI prevention, subject matter expert through the Society of Critical Care Medicine on the AHRQ, CAUTI and CLABSI and ICUs that had 6 cohorts where we got in the organizations and really worked with the teams that were challenged with higher rates of CAUTI and CLABSI. And interesting enough, there's a lot of rebooting and resetting going on of our cultures that is happening post-COVID because of some of the challenges that may have existed during the pandemic. And so I'm excited to spend some time with you this morning. I'm going to be asking you some questions. This one's focused specifically on CAUTI prevention and the provider's role. I am not sponsored by anybody for this presentation, but in the past I have been sponsored by these companies. And so I want to put that forth to you. So in the time that I have with you, I want to identify national trends in the CAUTI rate and utilization that's happened since the pandemic, really outline providers' role in reducing CAUTI and what are some of the barriers and the challenges that can be targeted from a individual perspective as well as an organizational perspective. And some of you may have seen this data. This was the comparative data that came out, look from NHSN, comparing 2019 to 2020 all the way to Q4. And you can see the rise in CLABSI was significantly higher, but there was an increase in CAUTI, and there was also an increase in the utilization of the urinary catheters, but also the length of time that they were in. A lot of times related to the ARDS patient that needed to be proned as a part of it. Also, just as a remark here, if you have ventilator patients, that the ventilator associated or secondary bacterial infections that happened with the ventilator patient increased significantly during that time as well. So just to give you an idea, this was published in 2017 by the government, AHRQ, estimating, looking at studies that were done in terms of mortality associated as well as the cost associated with a CAUTI. And just to give it a background, for every 1,000 in-hospital CAUTI cases, and I know you don't have that many, your smaller facilities, there are 36 excess deaths. So there is mortality associated with it, but more morbidity. If a catheter stays in, People walk less. They have a greater tendency for a pressure injury. So there are other impacts. And then when we're looking at average cost, it ranges anywhere between 5,000 and 22,000. 22,000 tends to be on the septic shock side of things. And so with an average of about 13,000 attributable costs. So it gives you an idea of both the financial as well as the personal cost to the patient. But really, it's more than a CAUTI. It's urinary catheter harm. And so even if you don't have CAUTI challenges, you may be having harm related to the catheter itself. Besides the trauma that some of the catheter can create, it does increase length of stay. You tend to be more immobile, which then has a series of issues, which can result in falls, VTE, and pressure injuries. So we need to think of that, having that catheter in a much more more beyond just CAUTI. And so can I ask the group this morning, you may not have, how many are having CAUTI issues and how many are having catheters in longer than they, let's ask the first question. How many are having catheters in longer than they want? Longer than they believe is necessary. Go ahead and put that in the chat box. I forgot to warn you. That's why I sort of was warming you up on the chat box. I tend to use it throughout the entire presentation. So go ahead and text that in there. Us, we have an influx of catheter days over the past 2 years. Okay, yeah. So we'll be talking about some of those strategies. And what I'm wondering, and thank you, Becca, for doing that. What we have to get back to is having data drive performance. And by the way, this is for our providers as well as our clinicians. Audits for appropriate indication. And we'll talk about how to get hardwired more on that. Also from an infection preventionist, and I know we have one, Krista, online here, is really sharing any data, whether it's an early or a late infection, and that's usually divided by the 5 days, and then displaying data that's meaningful. One of the things is I get into these clinical environments and I see data that's displayed in graphs. And I got to tell you, the staff, it just doesn't strike the individual as specifically by having graph data as it does displaying it. It's been this many days since we had this infection. And by the way, you can also utilize this kind of data for catheter days as well. So let's address some of the CAUTI through evidence-based practices. And I'm really going to focus on things on the provider side that can be addressed. And the first one is the marriage of the appropriate utilization of the catheter going in. So I'd like to ask, do any of you have set up in your EHR systems indications? So when a catheter is ordered, there's a drop-down menu in your EHR that requires the provider to put why the catheter is going in. Does anybody have that? I know it's 7 in the morning, guys. Not currently, we're switching and hopeful that it is. You really want to get to that point, because one of the things, and I'm also going to ask another question. How many of you have a nurse-driven removal protocol? Catheter removal protocol? I'm hoping almost all of you flag in with a yes. We initiated one, but providers still want to be called prior to removal. Okay, so we'll talk about some of those strategies, Becca, because that's an issue everywhere. May I ask, when you created it, did you get buy-off by your urologist? Because a lot of times, if the urologists are not involved in that process, there's a lot of hesitation in that. We do, but our nurses are reluctant to remove because providers want the control. We don't have a staff urologist. Becca, do any of your catheters get put in by urologists when there's a problem? Probably can't type as fast as I'm asking the questions, because one of the things, as you evolve in this journey to get the catheter out, you can also think about using that protocol to prevent the catheter from going in as a part of it. Yes, but very, very rare. Okay, so that's not the issue. It's more of a control issue. So may I ask, was the nurse, so this is a critical component, guys, was the nurse removal protocol bought off by the medical executive committee? Because if it wasn't bought off by the medical executive committee, that's a critical, yes, it was, Brandy, great. It is imperative that it's bought off by that committee. And then as the nurse uses the catheter, the removal protocol, the manager really has to back the nurse up and encouragement of that. And if the physician has a problem, say this was bought off by the medical executive, but when went to medical staff, they decided it wanted change to have, well, Becca, that's really not a nurse removal protocol then. Okay, that's a challenge. So, well, hopefully, yeah, right. Hopefully the evolution of that can be improved when you use data to show. Also, one of the things, because I would suspect in the ICUs that you have, that the catheters may be in there longer. Figure out your patient populations where they're in there longer, or individual providers where they don't want it removed, and start collecting that data of how long that patient is staying and what other potential complications may be present as a result of that, to help you bring individual data to those practitioners as a part of it. Also, one of the strategies, and this may be a little difficult, but getting the nurses that are encouraged to call for removal. If the doc says no, what's the rationale? And getting that rationale so that you can begin to educate and help understand the process. I hope that makes sense. So if you get the indications, guys, on the EHR, then you can go back, and then the nurse and the manager at the unit level can say, this patient no longer meets this criteria for having the catheter, so that they have more knowledge for why the physician put it in or why the provider put it in to begin with, and it starts the conversation. Now, one of the biggest challenges with the indication components of this is this one: urine output in critically ill patients or people that need specific measurement, hourly measurement of INO. May I ask, is this one of the rationales of why the catheter is staying in your environments? Is this what you're finding? Because as I cross the country, this is the one that is not as clear as these other components. These other ones are fairly simple. On the perioperative side of thing for selective procedures, is there a reminder order in the EHR that the catheter needs to come out 24 hours post the surgical procedure? So that's something that can be incorporated, sometimes more so for retention. Okay, so having, but the only way, all right, so let's back up for a second, because there's some structural things that are necessary to address urinary retention. So first off,
You doing okay?
are there bladder scanners?
Hello? Hello?
So you guys have bladder scanners so the nurses can assess it. That's good. That's important. All right. Do you have a good straight calf kit? So that's the other piece. Do you have good alternatives? And we'll talk a little bit more about the alternatives. So having those structures in place can help. So one of the things that the protocol, the nurse-driven protocol, is measuring the amount of urine every 6 hours for a 24-hour period and straight cathing. So in your nurse-driven protocols, what's the volume of urine before the nurse straight casts? Because when this whole initiative started, that volume was about 250 cc's. It's now between 400 and 600. We've learned that people don't pee with those smaller volumes. So making sure that in your protocol, you've got that larger volume, and I've got data to back that up. So that's one strategy. And if you can get them to remove it and run that Q6 hours, and then make a decision about re-putting the catheter in. So if we get to changing that culture, that there is no harm seen, because there isn't any harm seen, and that's what's happening around the country as almost like a national standard. And some places are pushing that out to 48 hours. If urine output is one of your components, especially in the critical care environment, in the Ann Arbor guidelines, which are the most updated that we have, it basically says indwelling catheters are appropriate for measuring and collecting urine only when fluid status or urine cannot be assessed by other means. So just being in the ICU is not sufficient enough. And really one of the strategies that when you're able to build it in the EHR is if you have critical INO, accurate critical INO, you can literally have a drop down under that as to what types of treatment really require that close urine output monitoring. And then if the nurses are prompting the physician with, do we still need this catheter in any round structure that they may do, whether it's in the ICU or the med surg environment, or a rounds process that may be occurring by the manager, instead of asking, do we still need this catheter? If the indication is for close urine output monitoring, ask the question, are we responding hourly to the urine output? Because if we're not responding hourly, then we have other ways of accurately collecting the urine output. And so what I would ask is, how many of your places still for the male have condom catheters for collecting the urine? Okay, one of the challenges with that is there are the anatomy of a lot of our patients. 1 out of every 200 men have a micropenis, and condoms don't work on those. They also don't work on buried penises. So there is more, and let me get the pointer here. There is newer technology, but they're hardly ever used. And the reason, Becca, why they're hardly ever used is because they don't work. So there is newer technology. This is called Male Liberty 2.0. And so it seals right on the glans penis. And every dude has every male has a glans penis. And you can see here, this one hooks up to suction. so it diverts the urine away. So that's on the male side. How many of you have the newer female urine diversion? So the male ones, this is the one that looks like a daisy is the Male Liberty 2.0. And the one that hooks up to suction is called Primo Fit. I'm glad to see, Becca, you have the female one, because these are essential equipments for the nurse-driven protocol to be effective and for the physicians to feel comfortable in knowing that their urine output is going to be managed effectively. So this is a critical component of this journey. And everyone, just to let you know, so Dana, do you have a way of being able to send this presentation out as a PDF to the people that participated?
Yes, we will send out slides, and we will also have them on our website. So we will make sure that they
Okay,
get them.
awesome. And so when you launched your nurse-driven protocol, what type of communication and education happened with the physicians? Did you share with them the significant amount of evidence-based literature in all the patient populations that have shown success of a nurse-driven protocol without harm? Was that part of your strategy? And because we have a small number on here, guys, if you want to unmute your unmute your microphone and talk about it, that would be great too. So what I would really think about, if you're concerned about the way it's launched or the way it's being addressed in the clinical environment, is one of the things, or two of the large things that really help physicians change their mind is data. So individual data on themselves that no harm occurred to their patients with this, and also what harm is occurring as a result of the catheter staying in longer than needed, and also all the evidence that shows the benefits of a nurse-driven protocol. So there are multiple retrospective and prospective evaluations of implementation of a nurse-driven protocol, showing a significant reduction in CAUTIs and significant reduction in catheter utilization. And so one of the things I may think about one of the things I would think about is really kind of regrouping to potentially relaunch this. And I would suspect all of your places have a chief medical officer or a chief of staff. And if they do, how involved was the chief medical officer? And they may be the chief quality officer, may all be one and the same. How engaged were they in the buy-off and the launch of this initiative? So I'm going to also provide you, and maybe we could put this in. Let me see if I can type it in the chat. ahrq.org. So the project that we did was 6 cohorts of over 500 hospitals in the country, is now in a toolkit on AHRQ. And if you go in, because it's new, it's still on the front page. It's broken up into assess, implement, and then my favorite section, which is overcoming challenges. And there's actually a make it work tip sheet. And one of the things, Dana, if you can take a note on this, I will get that make it work tip sheet so that I can send it. And it can be posted with this as well, literally on strategies to help better use of the nurse-driven protocol, both from the nurse and physician side, to help you with this journey. So some of the factors that affect success of this is really the communication patterns and the unit culture. If the manager and the frontline nurses work together to support each other in this process, they'll start to change the culture as long as they have good alternatives and you start to communicate with the physician. You can start to change that culture. It is not easy. The nurses are uncomfortable because all it takes is one provider yelling at them for them to be hesitant to use it again. Another is the right urine collection alternatives, which we talked about, the respect among nurses and physicians, and that's a cultural thing, and that takes a little longer process. And then from when you do have a CAUTI, local leadership and staff review of what may have created, what were the factors associated with that CAUTI. Feedback on catheter use. So may I ask, are you feeding the data on length of catheter use back to catheter utilization back to the units? You got it. So Lisa, no. Becca, yes. Guy, that's one of a critical thing. It's got to come back to the end users. So the data needs to be fed to the physicians and the provider group, and it also needs to be fed to the frontline individuals as a part of that journey. So the other area to tackle, and I know we could tackle a boatload, is the culture of culturing. So so may I ask, is there still a culture, no pun intended, within your environment to pan culture a patient when they present with a fever? Where the doctor orders blood culture, sputum, and urine automatically to cover everything. So pan culturing. So is there a, what's the best way to say this? Is it routine that when a patient has a fever, automatically they're culturing blood, urine, and sputum automatically without necessarily having indications? Not every time, but more times than not. Almost all of our facilities now have antibiotic stewardship programs. So one of my strategies that I share with clinicians is partner your change in urine culture process with antibiotic stewardship. So not in your ACU or ICU, but maybe an ER presentation. There's very specific components to ordering a culture. And what we've identified is asymptomatic bacteria. In other words, treating based on the urine culture, nitrates, WBCs without connecting it to signs and symptoms leads to about a 23 to 50% antibiotic inappropriate utilization. And interesting enough, this was a study published in 2021, or sorry, 2019. So it's relatively recent. That these are still indications people use for a urine culture. So we have to do education that these are not necessarily appropriate indications. So one of the strategies we talk about in the EHR is if the physician orders a urine culture, that you literally have a drop-down menu as to the signs and symptoms, so that you know that the signs and symptoms are being evaluated, or what the reasoning is for that culture, so you can determine appropriate culture. how many of your areas are doing, what is the recommendation when you have patients that are confused or unable to tell you you're not symptomatic or not? Well, acute alteration in mental status with clinical assessment negative for more likely etiology. So in other words, if they can't tell you and they're confused, but the confusion is not related to a septic process, they're confused because they have dementia, you need to rule out other sites before you automatically do a urine culture, is basically what the science is saying. So do any of you do reflex cultures? And Becca, that was a great question. And by reflex cultures, they order a UA, and then if there are a certain number of WBCs or nitrates, it flips over into a urine culture. Okay, so guys, one of the challenges with reflex cultures is the fact that if it flips over, you're doing it based on WBCs and a nitrate, and it's not connected to signs and symptoms. So there's two strategies to address that. One, get rid of reflex cultures altogether so that they have to send a urine culture based on signs and symptoms, or ask the laboratory to call the treating physician for the signs and symptoms before they classify it. Otherwise, you're treating an asymptomatic bacteria. So those are some of the things to think about. Also, may I ask what container is used to collect a UA that has the chance of going into a reflex culture? Is it the blue urine cup? The blue lid? Is it the blue lid? Yeah. So the other thing is if that urine sits there, it can cook all on its own. So if you maintain reflex cultures, really think about addressing changing to using the tubes with preservatives as a part of it. So guys, even if you're on the right track, you'll get run over if you just sit there, right? So we jam-packed heavily that 30 minutes. But I'd like to take the opportunity, and if it's okay, Margaret, and if the group is willing, if there's questions you'd like to ask me. We had a good conversation through the chat, but please feel free to unmute. Dana, is it okay if they unmute their microphone? Okay, so Margaret says it's yes. So
what questions does everyone have?
I'm going to shut off this and go straight to participant view. And by the way, feel free to turn on your camera. We can do a Brady Bunch. So questions, guys. I tossed a lot of information. Oh, the other thing, because you guys are having longer utilization days, if somebody is drawing a culture, APEC recommends that if the catheter has been in greater than 2 weeks, the catheter should be removed. And if the patient still needs a catheter, another goes in, and the culture is then drawn from the new catheter. Now, this is also an opportunity to take it out and do an intermittent to get the culture. Now, that's APEC, but I will tell you, organizations have moved that to 3 to 5 days because they've done their own quality initiatives. And there's also some published research where at 5 days, they've drawn the culture before they remove the catheter. They removed the catheter, put a new one in, and then drew another culture. It was positive over here and it was negative over here because of the bacterial biofilm on the catheter itself. So those are some things to think about. So let me ask you a question. What's your biggest issue? Sounds like it may be buy-in on the nurse removal?
Hey, this is Becca.
Hi, Becca.
Thank you. I've appreciated your insight. It's been good. So our catheters, like I said, the length of days has been increased, but we necessarily haven't seen an increase in infection, which is really good.
Yep.
But sometimes I feel like that kind of downplays the importance of getting those catheters out because I don't have that data to support, hey, we are getting infections from these, if that makes sense. And then another barrier that we had earlier on, which I feel like is getting better, sometimes it's not always our physicians putting in those catheters from the get-go. It's the nurses requesting them because of frequency or patient complaining. And I don't necessarily think the proper education from staff to patient is there. And that kind of goes as well as the urine collecting too. Like our nurses will say, hey doc, the patient's urine is dark and cloudy and foul smelling, without necessarily the symptoms behind it. So we have some opportunities there.
Yeah, it sounds like education on those specific issues. And by the way, there's a lot of free stuff on that AHRQ toolkit that you can get to use for education as a part of your journey. But it sounds like focusing on some of those specifics and really maybe using that urinary harm and not just a CAUTI, but that urinary harm picture to start your journey, Becca, so that
I did like that. I wish I would have used that from the get-go. That was nice.
Yeah. So that came out through this AHRQ work in the partnership with patients and patient safety. Other questions?
One other big win for us was we do a lot of total joint replacements, so knees and hips. And we saw opportunity to get those out a lot earlier. So I don't know if other facilities are on that would benefit from that, but that has helped us tremendously. In our orthopedic surgeon that comes, he was the big driver with that because obviously they're his patients that go into surgery, and he was totally okay with getting those out right away. So that was a big win.
And interesting enough, there's a lot of those that are not even putting them in anymore.
Yeah, we talked about that. So
I know it may be radical right now, but
we're gonna circle back around to that at some point in time. Yep.
Yeah, no, that's great. What other major barriers are you guys experiencing? We'll also have the opportunity at some of the workshops to dig into this stuff too. All right. Hi, Amber.
Good morning. I was just going to say that I would say knowledge is kind of the biggest barrier because I've learned a ton today. So all of the different equipment that's available. And I would just say listening to other hospitals and kind of hearing what everyone else does, I feel like I have a lot more to learn. So I appreciate all of the insight and have definitely learned a lot this morning.
Well, and Amber will also, I'll go in more depth with each of these at the noon or your 11 o'clock CAUTI one. And then we'll, so one of the reasons why I like to get into hospitals and get into the equipment rooms and see processes and practices are literally that variation and what's there and what's not. That is making it easier for staff to do the right thing and for clinicians to do the right thing. So I look forward to that opportunity.
Awesome.
Thanks for sharing. All right, we're over, but this was, I hope you all hung in there. So I think unless there's any other questions. So by the way, you guys will have my email address, you know, because it'll be on these slides. So you can always independently or individually email me if you have any questions. Okay.
Awesome. Yes, thank you so much. And yes, we will get all this information out to everyone soon. soon. So be watching for that and share with your providers and use the information to move practice. So we're really excited. Kathleen, it was so good. I learned something. I know very little, but honestly, I learned something every time I listen to you. So thank you so much. But we look forward to having the next installment coming up later today and then a couple more next week. So if anybody has questions in the meantime, reach out to Amber and I, and we'll make sure you have Kathleen's information right away, but we will get everything out to you soon.
And
So be watching for that.
And thank you guys for participating. It makes it much richer when we have a conversation about the challenges and what's working and what isn't.
Absolutely. All right, guys, have a great rest of your day, and we'll see hopefully some of you again later today. And thanks. See ya.
Bye-bye.